Hello, I'm Dr. Richard Becker. On behalf of the faculty and staff at the University of Cincinnati Heart, Lung, and Vascular Institute, it's my pleasure to welcome you all to Scholarvision. Today I'm joined by two colleagues, Dr. Satya Shreenivas and Dr. Imran Arif. We'll be discussing a new and very exciting program at the University of Cincinnati Medical Center that is dedicated to structural heart disease. Gentlemen, welcome to Scholarvision. Let's talk about structural heart disease. I mean, it is something that has emerged very rapidly over the past 5 years or more in the States, perhaps a little bit longer in Europe. But Dr. Arif, maybe for our lay community, if you can describe what structural heart disease is all about and why it's so important.
So once again, thank you so much for inviting us here. As you know, in the field of interventional cardiology, the structural heart disease is a rapidly developing subspecialty. And in the last 5 to 10 years, patients who have had either heart defects by birth or have acquired defects in their valves or certain areas of the vasculature, such as the big artery aorta, those diseases, as more and more treatments have evolved with percutaneous therapies, in minimally invasive therapies, and essentially in combination of all these different procedures that we can do to sort out and treat these problems is what we combine as structural heart disease.
Yes.
In this era.
Yes. And Dr. Shreenivas, tell us a little bit about the specifics. What are we talking about here?
So structural heart disease is really any defect, any problem with the heart that doesn't involve the actual blood vessels, the coronary arteries. Now, traditionally, this has been divided into 3 big categories. As Dr. Arif absolutely mentioned, the diseases of the valves have taken front and center, front page on the New York Times, how we can fix these with valves that can just be delivered through the leg and the patient goes home in a couple of days. So valve disease is certainly a big part of what we do. Congenital diseases, Dr. Arif also mentioned, patients that at a young age were born with a heart defect, and as they've grown older, either the defect has gotten worse or the therapies we did 30 or 40 years ago have developed problems, and now we have to fix those. So congenital defects is certainly a big part of what we do. And lastly, problems with the muscle itself, the heart muscle itself. Maybe a piece of the heart muscle is too big. It's getting in the way. Hypertrophic cardiomyopathy, it's something we can get rid of with a simple ablation. Or sometimes a part of the heart's diseased, and you can actually partition or exclude that part of the heart. These are all, they all fall in the realm of what we call structural heart disease, a very broad field that's been growing very, very quickly.
Yes. Now you mentioned heart valves, so let's start to focus a little bit on aortic stenosis, a very common, acquired, in most instances, anomaly. And Dr. Arif, if you can tell us a little bit about the non-surgical approach to valve replacement.
Correct. So one of the areas that really the structural heart interventions have really blossomed in the last decade or so, first more in Europe, and now the US in the last 5 years or so, is the treatment of a valve condition where the aortic valve doesn't open well, it's stenotic. Patients who have significant symptoms of shortness of breath and congestive heart failure, passing out. In those patient subset population, we have developed a technology where you can deliver a new valve through percutaneous route, either from the femoral approach or from the arm approach, or even coming from the chest wall with minimal invasive incision. And as a result of that, you pretty much treat the aortic stenosis without opening the chest wall in a patient.
Yes. Sounds particularly attractive as an option for patients. Tell us a little bit, Dr. Shreenivas, about the team. I mean, this obviously is something that requires a team approach.
It absolutely does. Here we have a fantastic group of very hardworking and very group that works incredibly well together. The team starts off with nurses, technologists that are devoted and are very well trained in doing these procedures. You have anesthesiologists that do these procedures with us very closely. Of course, you have our imaging specialists, our echo, our CT experts. You have our adult congenital specialists with our close collaboration with children's hospitals. You have our surgeons, not just your cardiothoracic surgeon, but also our vascular surgeons that are incredibly amazing. And then you have your cardiologists, you have your echo, your interventional, your adult congenital, that all work very closely as a very tight-knit and a very hard-working team. And the glue that holds it all together is a valve coordinator, someone who's the quarterback of the team that makes sure that the patient, the family members, the referring physicians, and the physicians that are all part of this big team all work very closely together.
Yes. Let's talk about the program that's being developed at UC Medical Center. Dr. Arif, it's something that's in evolution. There's a new hybrid operating room. So what's the next step in terms of what patients need to know, what physicians who have patients with structural heart disease abnormalities, what do they need to know about the program?
Yes, so as a part of the media outlet, the patients need to know that now at UC Medical Center, the leadership and the hospital committed a $5 million new hybrid operating room that's now available at the hospital. And as a part of that, the whole structural heart team, which Dr. Shreenivas is now the director of the structural program, is put up together with different subspecialists that we mentioned. So now we're going to develop a valve coordinator and a valve clinic. We have already started to see some of these patients come through our hybrid OR operating room. Procedures such as atrial septal defects, PFOs, alcohol septal ablations are being currently performed. MitraClip is the next frontier that we're going to start pretty soon, and eventually transaortic valve replacement would be something that hopefully in the near future we're going to offer.
Yes. Now, both of you have mentioned adult congenital heart disease. Let's talk a little bit about that.
Absolutely. We have a great opportunity and a very close collaboration with our colleagues across the street at Children's Hospital, and I think it's a natural collaboration. You have some incredibly well-versed, very talented physicians that have been taking care of kids as they grow into adults over the last 40, 50, 60 years, actually even longer. Those kids, as they grow up, though, have adult needs. And we have the skill set, the tools here to take care of adults, and we have a close collaboration with Children's Hospital, with physicians there that have known these patients for long periods of time and have really gotten them to this point. We have a very close collaboration with the adult congenital cardiologists and also with their interventionalists. They'll come over, we'll do cases here together. Occasionally we'll go over to Children's Hospital and do cases there. And I think this, at the end of the day, all of this serves the patient very well. They get a seamless experience and they get the best of care with two teams that work very closely together.
Sounds like a wonderful opportunity for the community.
I would like to build up on that as well.
Please, please.
I think the biggest change, and I know you has also noticed this, is as a trainee in the late 90s and early 2000s, where one would be working in the cath lab by himself and doing some of these percutaneous coronary procedures. In the last decade, with all these changes and these new procedures that have come, the biggest change that has come in cardiology is the heart team approach, trying to put a group of people together in the room to achieve the best outcome for the patient is the goal. And I think some of these complex diseases that we are now treating percutaneously require really a very strong collaboration from our congenital heart disease children experts, from our imaging experts, and from our interventional cardiology and CT surgery. So that's the biggest change that we have achieved in trying to put a team together and hopefully have the best outcome.
Absolutely.
And I certainly like the way that sounds, where you have the best of the best that are working together, and that the patient is the beneficiary of all of that training, all of that communication. So it's a very exciting time for our community.
Absolutely.
I'd like you both to comment on where we'll be 5 years from now. Obviously, this field of structural heart disease has really taken off. Where will we be 5 years from now? Dr. Arif.
Yeah. Like anything we do in science, I think first is we need to do better with what we are doing currently. And I think the most important thing is the transaortic valve replacement, which is really a fantastic new therapy to offer to a huge number of patients. I think we're going to see much lower profile valves, we're going to see newer valves, and we're going to see much more deliverable valves. And hopefully, we don't have to do cut downs from the chest wall or from the other areas, and we just be able to come from the groin. So whatever current therapies are, we're going to do better on those as the technology evolves. Along with that, on the same lines, I think the next frontier is going to be the percutaneous mitral valve and tricuspid valve therapies. I think their replacement, their repairs, this is something where transaortic valve replacement was 10 years ago, is where we are our field right now. So I think what you're going to see over the next 10 years, really these technologies will evolve. And I'll let Dr. Shreenivas add some more to that.
No, I couldn't agree with Dr. Arif anymore. I completely agree with him. I think progress will be in three pathways that will all happen together. As Dr. Arif mentioned, the first will be perfecting what we have. Valves that will be smaller, more deliverable, just like our coronary stents. The initial ones compared to what we use now, newer and newer generations. It's almost like the iPhone. The first one was amazing, the first coronary stent was amazing, and then the subsequent ones kept getting better and better and better. The second part of this will be TAVR-related technologies. So can we access the heart via different mechanisms? And there's a huge field on making sure not only do we get the valve where we need to in difficult cases, but also how do we minimize the complications? So devices that decrease the stroke, that can deflect emboli to other vascular distributions. So TAVR-related technology will be the other growth field. And then finally, other valve therapies. When you're talking about innovation in the valve space, other valve therapies, the mitral space has been much, much harder than the aortic space. The analogies you hear people joke about, it's like driving a car versus flying a plane. Much more difficult anatomy, a lot of other variables, but you have a tremendous number of companies working very hard in this space and trials that have already started on percutaneous valve replacement, not just like MitraClip that's available right now, that's a repair, but an actual replacement. And lastly, the one last thing I would say is we're talking about structural heart disease and we're talking about the valves, but really, 10 years from now, who knows where we'll be? And to hammer home that point, 30 years ago, 35 years ago, the cath lab was a completely different altogether. It was mostly a diagnostic lab. Even 15, 20 years ago, if you had a heart blockage, it was surgery. And so 5, 10 years ago, most patients were still getting their valves fixed surgically. So where we will be 10 years from now, I think we look forward to, because I think the innovation's fantastic.
It's an exciting time, and obviously part of it is doing combined procedures where you might repair a valve and then replace a valve. And you'll work closely with your surgical colleagues, because there'll be some cases where part of the work will be done percutaneously, part of it will be done surgically. And I look forward to it, and we're certainly pleased and proud to have a program like the ones that you have developed here at the University of Cincinnati. So thank you very much for all of your hard work.
Thank you very much.
I'd like to thank Drs. Arif and Shreenivas for joining us today on Scholarvision. We've had an opportunity to discuss structural heart disease and all the excitement that it brings to the University of Cincinnati Medical Center. Until next time, keep asking questions. Inquiry is the true compass to scientific and medical advance.